Uh, in case of a very severe systemic disease in a diabetic patient undergoing dialysis, and patient cannot go for transplant, and the patient is being treated for a long time. So if the patient develops severe diabetic macular edema or advanced diabetic retinopathy proliferative, what is your take in management? And if you want to give anti-VEGF, which anti-VEGF would you prefer?
Yeah, I think Rajiv Raman's talk is there for that. But we have what I would suggest is whatever ocular treatment you are giving is a temporary solace, because severe nephropathy, these patients tend to have the risk of accumulation of the fluid in the macular area. So treatment for a severe nephropathy is renal transplantation. Unfortunately, in our country, the waiting period for renal transplant is very high. So temporarily, you need to maintain the macular thickness to maintain the vision, so that we should not lose whatever clinical uh, the potential, visual potential the patient is having.
And regarding the anti-VEGF, what would you prefer if you want to give?
That is your preference rather than my preference. Any anti-VEGF, or we are dealing with that actually. The talk is there. That's why I don't want to answer that right
Okay,
now.
thank you very much.
Yeah, Dr. Ajay.
Thank you, Dr.
Dr.
Babu.
Vishali, you can continue your this.
The topic that has been given to me is the diagnostic evaluation of diabetic retinopathy and DME. So far, Dr. Babu explained it beautifully that when you look at the fundus, you need to first characterize whether it is a non-proliferative diabetic retinopathy or there is a proliferation of abnormal vessels. Now let's go step by step. You have done your fundoscopy and you know it's non-proliferative diabetic retinopathy, which could be very early or which could be more advanced like moderate. The first question that one should be answering is there an associated macular edema? So for that, the only investigation that helps you answer the question straight away is the OCT. OCT, simple line scan, or a cube, but the line scan, if you are analyzing, it should be passing through the fovea. Now you look at the OCT and you do understand there is macular edema. When you look at the macular edema, just look if there is any traction or not. If there is a traction, don't try to think of the medical management. Now, if there is no traction, which is so obvious on OCT, the next question to answer is it center involving or is it not involving the center? Because if it is center involving macular edema, it will require anti-VEGF therapy. But if it is not center involving macular edema, you might be able to get away with simple focal laser and does not require repeat injections. So now let's assume it's a non-center involving. What should be done next? The next is to look, are there any microaneurysms? Yes, there are microaneurysms which are away from the center, which you feel you can do laser. Then now here comes the role of the angiogram. You do a fluorescein angiogram to document those microaneurysms because you want to be very sure what are the areas that you are leaking for. So the fluorescein is not required to make the diagnosis of macular edema, but it is important to identify the treatable lesions in case you decide to go ahead with laser photocoagulation. There comes another thing. All our lives we have been told to focus on the posterior pole because we always thought that the diabetes involves the posterior pole and we would not even bother to look at the periphery, but not anymore. With the wide field, your posterior pole apparently might show, it's okay, it's NPDR, But if you are seeing any occluded vessels, any areas which are suspicious in the periphery, please do not believe it could not be PDR. It's important to do an angiogram, and you would realize that if you look only at the posterior pole, it's kind of severe NPDR with macular edema. But when you look at the periphery, there are changes happening in the periphery. So fluorescein is going to help you identify the new vessels whenever you are in doubt. Dr. Babu showed beautiful ARMAs, but it's not always very easy to differentiate an ARMA for NVE. So whenever in doubt, the fluorescein would be required to answer some of these questions. So here is a simple algorithm for non-proliferative diabetic retinopathy. If it is mild to moderate, check if there is macular edema. You can, up to this point, actually you can do clinically, but you can take the help of OCT just to say, if you think macular edema either is present or you're not sure, it's fine not to be sure, you're just suspecting, do an OCT. OCT shows center involvement, it's good idea for injections. OCT shows non-center involvement, you are planning focal laser, please do a fluorescein before focal laser. If it is severe NPDR and you're not very sure that you can see NVE, it's always a good idea to go ahead with fluorescein angiogram and of course OCT along with it to look for macular edema. When we come to proliferative diabetic retinopathy, most of the time it's on our face. For example, you have these huge preretinal bleeds or something, so you would know it's proliferative. But sometimes what happens, this patient look like this at presentation. And when you look at the presentation, your macular edema is very overwhelming, but there is a fine NVD which was missed at some level. So please pay an attention clinically, and if not sure, get an angiogram done, because this patient at this point of time required treatment for proliferative diabetic retinopathy, but the very fact that he was labeled as severe NPDR with macular edema and sent for systemic control, including lipid lowering and all, he comes up like this. 50% of these patients with very severe NPDR would progress to PDR in 1 year. So in severe NPDR, it's important to look for the features. And sometimes you look at the retina. For example, this retina is not looking good. Multiple cottonwood spots, kind of ischemic looking, and you are not able to clinically be very sure whether it is NPDR severe or proliferative, and these are the cases which will end up in vitreous hemorrhage. But if you do fluorescein, you would realize there is lots going on with capillary non-perfusion, and this patient needs good early management. Now, we have covered both the NPDR and PDR. Now, OCT shows macular edema, and I'm going to just go in passing. What do you look for? Besides the traction, non-traction, macular thickness, there are a couple of things which comprehensive ophthalmologists can pay attention to. And first of them is drill. Drill is nothing but when you see the inner retinal layers are disorganized, for example, you see here, you don't see them separately. It simply means that patient may not have a very good visual recovery following your anti-VEGF injection. So you can counsel the patient regarding that. This is what a magnified view of drill is. Sometimes you see such huge spaces that the outer retina, this is the external limiting membrane, and you see it's all disrupted. Again, if this is disrupted, don't be tempted to put more laser. You see already somebody's done a lot of laser. Don't put more laser, because this are the kind of the patients who are not going to improve vision. So make a conscious decision and counseling with the patient before pumping more anti-VEGFs. Hyperreflective foci, you will see many retina people talking about these hyperreflective dots, which can be easily seen by anybody. You don't need a retina expert to look at these hyperreflective dots. These dots basically means, especially if they are associated with this kind of serous detachment, means inflammation is playing a very important role and anti-VEGFs may not work, and you may need to switch over to steroids early in the course of the disease or seek the help of your retina colleagues. Same is the situation with subfoveal serous detachment, especially if it is coming after your colleague has performed a cataract surgery. These are the kind of the patients who would respond better to steroids than to anti-VEGFs. Pre-retinal bleed, you don't have to do anything. Just go ahead with the management of PDR. Advanced tractional detachment, no role of angiograms or OCTs. Just refer it to your retina colleagues for, treatment. And lastly, if you are seeing NVDs like this, these kind of NVDs, don't waste your time on angiograms, because while you are waiting for angiograms a couple of weeks or referring, patient might end up with a bleed. So these are the kind of the situations, like even if you do angiogram, it doesn't give you information. There is NVD. It needs to be managed by angiogram, you know. So some of these situations need to be managed. NVE, you are seeing a straightforward NVE, no need for angiogram. You are not sure, as I showed earlier, please go ahead with the angiogram. So whenever in doubt, for example, this patient, very fine NVD, you are not sure, angiogram to confirm. So to conclude, the diagnosis of diabetic macular edema and diabetic retinopathy is primarily clinical, and Dr. Babu has shown a beautiful presentation how to diagnose it clinically. FFA, OCT are the two main imaging modalities, but everything doesn't have to be done in every diabetic patient. So you have to characterize the diabetes and then do what is required for the patient. And please note that fluorescein is not a modality to follow up your patients. It's just initially when in doubt, but you don't follow it up on fluorescein and repeatedly. These are not required to make the diagnosis, only in some treatment decision making. So they should be used as and when required. Thank you very much, Dr. Babu, once again, for the very kind opportunity.
Thank you, Dr. Vishali. Are there any questions for Dr. Vishali regarding the diagnostics in diabetic retinopathy? I request Dr. Ajay Arora to be ready for the presentation. Yeah.
We have
Dr.
not
Vishali,
shown,
fantastic talk.
Thank
an
you.
OCT of traction. VMT, vitreomacular traction, or there's.
Yeah, that is what I said the first thing. I forgot actually to put the
But one slide
OCT.
would have been-
That once we do the OCT, what we have to decide is it a tractional variety or non-tractional variety? The tractional variety is going to show you the pull on the fovea. If it is a tractional variety, please do not do any injection or laser. Just refer it to the vitreoretina colleague. If it is non-tractional, that is what I have shown, the non-tractional variety of macular edema. Then you see center involving, non-center involving, and go ahead.
Okay. Next.
Yeah, Dr. Vishali, very good talk.
Thank you.
Just two questions for you. One is that in doubtful cases of severe NPDR, where you're suspecting a proliferative disease, you said one of the best treatment modalities or investigative modalities has to be an FFA to confirm the proliferative. Sometimes we have seen that the retinal vasculature, the retinal veins are actually more dilated in the quadrant where the NV is eventually going to be located. So could that be one of the findings or one of the signs where you can actually suspect that there is a probable neovascularization in a patient with PDR? That's my first question. And second, is there a difference between a neovascularization arising from the disc vessels, that is the NVD, and a peripapillary retinal neovascularization? Is there a difference between these two entities, or both are the same?
Answering the second question first, the definition of NVD is any new vascularization arising from the disc are within one diameter of the disc. So the peripapillary is automatically covered in the definition of NVD, so everything becomes NVD. Now coming to first question, that when we look at the AV ratio, what essentially you are talking about, does it give us a clue about the overall health? That's a beautiful subject, and actually we are presenting a paper here also where we are making it automated. Like instead of you saying 2:3 and me saying 1:2, we are developing an algorithm called retinal health index. So it's semi-automated. You do it, it gives you a value that this is the health. We have not tried it in diabetics, but in BRVO patients, it shows even in the opposite eye, the AV ratio is altered compared to the normal controls. But I think very soon we will have these kind of algorithms. But if you are suspecting, please go ahead and do angiogram. There is no harm.
Yeah, but in the clinic, especially for a general ophthalmologist, to concentrate on venous dilatation to identify the neovascularization is not a good suggestion.
Yeah.
I always consider me as a general ophthalmologist in the clinic not missing severe stages of diabetic retinopathy or diabetic macular edema. So vision threatening diabetic retinopathy is one which they should identify early and send to the retina specialist. That is my target. Okay, quick question from you.
Ma'am, thank you for the presentation. Ma'am, you showed that image of drill. Ma'am, we had that lesion in the parafoveal area. So if it is present there, would it still have a bad prognosis for the visual outcome? And if it is present more in the foveal area, will it have a better visual outcome?
See, we got to treat them anyways. These are just fancy terms which you hear in the VR. I don't believe in most of them, but I think comprehensive ophthalmologists get intimidated by them. So I just included to be familiar with them, but you got to treat them only you counsel the patients.
Yeah.
Thank you.
Instead of they breaking their head about all these fancy terms, they should know this terminology and what it could lead to when they find on a OCT in their clinic.